Hello, everybody. Good afternoon and welcome. My name is Tamsin Rose, and I have the great pleasure of being your moderator this afternoon. And we're delighted to have this session, which is supported by Amgen and is part of the European Health Forum Gasteins conference. And just to make the link, the focus, the theme for this year is Rise Like a Phoenix, Health at the Heart of a Resilient Future for Europe. Well, guess what? We're going to be talking about what's at the heart of our health issues, which is cardiovascular disease. And today we're going to be exploring why we need to have a plan for cardiovascular disease in Europe and how we get there. So welcome to everyone who's joining us. There's a few basic housekeeping rules I'd need to introduce you to. We would like to interact with you in a number of ways. First of all, you'll see at the bottom of your screen, you can chat with us and you can also use the Q&A function. And towards the end of our webinar, there'll be an opportunity for you to ask questions. So please feel free to put your questions in the Q&A section. If there's a comment or something else you'd like to add through the chat, please go ahead and do that. We're also going to want to interact with you using Slido. And there'll be opportunities. We're going to ask you polls and two different opportunities. So you will be either able to follow the link in the chat, or we'll also post a QR code on the screen that you can take a photo of with your smartphone, and it will take you to the relevant page on Slido. The hashtag that we'd encourage you to use is the EHFG 2021, which you can use on both Twitter and LinkedIn, and that's a way of keeping the conversation going. So just as a reminder, we're here discussing cardiovascular disease because it's still the #1 killer in Europe. And if there's one thing we should have as a goal in health, it's to tackle the largest burden of disease. And so that's why we're going to be addressing it. But to give you a little bit more detail, and certainly with someone who has a lot more authority on the issue, I'm delighted to introduce Professor Steven Achenbach, who is the president of the European Society for Cardiology. And he's going to tell us why Europe needs a Beating Cardiovascular Disease Plan. Professor Achenbach, please go ahead.
Well, thank you very much, Tamsin. Thank you for the opportunity to speak here. And I couldn't agree more with you that Europe certainly needs a very good and a very strong plan to beat cardiovascular disease. And I'll try to give you 3 good reasons for this. If you go to the next slide, first reason is, as you already mentioned, that cardiovascular disease is and remains by far the most frequent cause of death in the world. Here you can see the statistics of the causes of death per year globally, and you can see that cardiovascular diseases cause almost 18 million deaths every year, by far more than any other disease group. That's 31%, 1/3 of all deaths. And of the deaths caused by cardiovascular disease, about 85% are due to heart attack and stroke, the biggest components. In the European Union, it's similar. 30% of all deaths are caused by cardiovascular disease. It is the most frequent cause of death. 1.7 million individuals, that is, every year. And if you look at the subgroups, so to speak, what surprises many is that in women, the percentage of deaths caused by cardiovascular disease is higher than in men. And if you compare the percentage of deaths caused by cardiovascular disease, 37% overall, is significantly higher than cancer if you take the European Union as a whole. There are some countries where cancer is more frequent, but in the totality, cardiovascular disease is significantly more frequent than cancer. So it is a massive problem, but there is a misconception out there, sometimes by those who are not so well informed, that cardiovascular disease is mainly a problem of the old. Yes, elderly individuals suffer from cardiovascular disease, morbidity and mortality, but cardiovascular disease certainly also affects young people. I had been preparing these slides a few days ago, and on that very day in the morning, into my apartment was admitted a young girl, 19 years old, who had gone running in the woods and had a cardiac arrest because she has a congenital heart disease, which is called hypertrophic cardiomyopathy, 19 years old. Luckily, her condition was known. Luckily, she had an implanted defibrillator who saved her life as she was running in the forest. So cardiovascular disease certainly affects young people. And if you look at the numbers, next slide, please, you can see that even in those which we consider premature deaths, less than 65 years of age, 17% in women and 24% in men are caused by cardiovascular disease. And because cardiovascular disease strikes the young, a lot of people are living with cardiovascular disease. We should not just limit our attention to mortality, the burden of morbidity, the individuals living with cardiovascular disease, 60 million people currently in the European Union. And we estimate that 13 million new cases of cardiovascular disease are added every single year. And if you know what it means to live with stroke, for example, not only for the affected patient, but also for the family, you can imagine that this burden is truly massive. So cardiovascular disease certainly also affects young people. And a third very important reason why we need a plan for Europe is the inequalities that we see in Europe, in the European Union. According to the country you live in, the risk that you will die of cardiovascular disease is significantly different. There's a gradient basically going from west to east. You can see the green countries where the risk, according to the WHO, is less than 70 cases per 100,000. To countries in red where the risk is more than 300 cases per 100,000 of cardiovascular disease. So a significant difference from country to country. If you look at the specifics, here are some examples. For example, if you look at coronary heart disease deaths, and here we're looking at deaths per 1 million inhabitants, the rate can be as high as 5,600 per 1 million in Lithuania, and as low as 470 per 1 million inhabitants per year in France. So significant gradient of risk, which means there's a lot that can be done to attack and to address these inequalities, and a lot that has to be done to address these inequalities. So next slide, these are my reasons why I'm absolutely convinced that I put a big part of my working life behind this, that we have to have a plan for Europe. It is the most frequent cause of death. It's not only about death, it's also a massive burden of morbidity that we carry along with cardiovascular diseases. It certainly affects all ages, and there's substantial inequality. Thank you very much for your attention.
Thank you very much, Professor Achenbach. You've made a very compelling case about why we need to do something, why it's urgent, and why at European level we need to be doing what we can to raise up the levels of countries that are doing very poorly in comparison to others, to create, you know, a better quality of output and outcomes for everyone. So that's clear why we need a plan to tackle cardiovascular disease, the enormous burden, the high numbers of people coming in it, the inequalities and the misconceptions that we have, which means we're not doing our best because we're suffering under blinkers that it only affects a certain number of people in a certain way. So now let me invite Birgit Bigger, who is the CEO for the European Heart Network, to give us an opportunity to understand how we could drive positive change through a policy action for cardiovascular disease. Birgit.
Thank you very much, Tamsin, and welcome everybody. And thank you for the invitation to the session in Gastein. Virtually or not, we'll have a good session, I'm very much sure. So I'm representing the European Heart Network. It's a Brussels-based alliance of foundation associations dedicated to fighting heart disease and stroke and supporting patients throughout Europe. So our vision is that every European has a right to a life free of avoidable cardiovascular diseases. So what I'm invited to speak about is about policy action and positive change. So Professor Achenbach explained why we need the CVD plan. It is the highest killer number 1 in Europe and worldwide. So it is the burden, of course, but what do we do? Already last year, we published a blueprint, what the European Society of Cardiology and the European Heart Network thought are important pillars of action to be taken. So I'm taking you a little bit through that, and you will see that we have a very nice publication. It is here. and followed also by a nice leaflet. You will see on the next slide, this one, which shows principal actions. First of all, we think about preventing, and there we have healthy lifestyle. It's always better to prevent than cure. So a lot can already be done if we attack risk factors. That is smoking, that is obesity, that is a sedentary lifestyle, but there are other factors coming in there as well, which will help that the risk for developing cardiovascular disease is lowered. And that for this we need ambitious EU policy and regulation, because we believe that if a regulator steps in, member states are forced and can enforce a policy which creates a healthy environment. So the citizens and people have the choice for a healthy lifestyle. Then Professor Achenbach mentioned it already. We are looking also in equality, because there is this huge disparity within the EU and even the wider EU. The further you travel east, the less you have healthy lifestyle, the less you have an infrastructure, a health system which supports the patient. So here is a huge inequality, and this is just not correct. So we have to address this. Then we also know that we need to advance knowledge, because without research and innovation, we will not get forward, we will not make progress. And there has been a bit of a stagnation in the last years. So we would love to see more EU funding directed to cardiovascular disease, because innovation is there. A lot of scientific evidence is undertaken. There are ideas, but they need to put into clinical trials, research proposals, so that it can be taken up. We can harvest the knowledge which is out there if you put it into a proper research. Then we also come across that it's discussed everywhere, the need for data and digitalization, and this goes hand in hand to collect data in a good manner, so that we have registries for patients in order to steer continuous quality improvement, and also help us with clinical trial safety, and also later on for the surveillance of new treatments. So I think that is a very important aspect which needs to be developed in a future policy action within Europe. Then, of course, we can't look into it with just our single EU member state knowledge and health system. We need to transfer the knowledge and learn from each other. What are best practices? What works well? What doesn't work well? So this is another very important item, that we have a coherence in the in a transfer of knowledge in prevention, diagnosis, and management. So this it's in a nutshell what the blueprint for EU action has foreseen, which we've developed. It's of course underpinned by more specific recommendation, which you will also find in that brochure. And maybe I already only highlight one or two. Namely, already when we published it, we had the idea that we need to have a structured collaboration between academic clinical trialists, patients, regulator, and industry to modernize what we here call the International Council of Harmonization Good Clinical Practice Standards, and how to make them fit for the digital area. But as you see, we already thought that it is very good that the doctors and the patients come together and think about actions, but that we could go much further if we had more partners, if we really were multidisciplinary, and if we really were multi-stakeholder. So it is my great pleasure to also mention, which Tamsin helped to bring on to birth yesterday with the launch of the European Alliance for Cardiovascular Health. It is very positive to have a positive outlook. So we do not talk about this disease all the time, we do talk about health. So and with this alliance, we brought together a very big group. It's I think 15 we are in between, getting 16 I think. So there are different sectors coming together. It's the cardiologists, of course, the patients from different disease areas within cardiovascular disease, because it is a big range. Then we have the insurers, the health insurers on board. We have inter alia, also the industry represented through the association, trade association, pharmaceutical industry, medical device industry. It is a huge network, and I will not be able to list all of them, but it's a very good start for a collaboration where we try to create a more awareness within and get into a dialogue with policymakers, which we'll meet in a short while later in the session with the help of Tamsin, and discuss what can we really do now to foster this plan and have solutions there, because we are such a group which brings together so much knowledge, expertise, and you can find not at every street corner, but it is really a very good group and a very good group of experts which can help to put for the EU and also at national level to put CVD into focus and change indeed the life for the patient. I think we are time-wise, Tamsin, how are we doing? We're doing fine. So, and I think I'm looking very much forward that this group each has been launched. And we will have tomorrow, of course, the World Heart Day. And I think that all the members of this group will have specific positions and actions to put forward. So I'm very much looking forward to that. One topic, for example, prevention is tobacco. Tomorrow, EHN will publish a paper on heated tobacco products. So I think every member of the Alliance will bring forward their specific agenda, and we will see where we find consensus and where we can contribute to a policy and to an action in the different programs with the EU. But last but not least, we do not want to forget the national level, because there is where the health systems are. There's where we need to change the life for the patients and also for doctors working under the conditions to make it really a system which allows for improvement of cardiovascular health. So I think I put the point here because we want to be interactive. That's I know. So we need to talk to each others together and on our own. Very good. Thank you for your attention.
Thank you very much, Birgit. And exactly on the issue of interactivity, we're going to launch a poll via Slido, which is going to ask you a question. But just to do that, a reminder that we've got in the chat, if you have a look, there is a link to app.sli.do, and then it gives you the specific link. And we're going to ask you to create a word cloud, and you do that by just putting in one word at a time. And the question that we're going to ask you is, what do you think is the most urgent issue we need to address to tackle cardiovascular disease in Europe today? Now, both Professor Achenbach and Birgit have set out for you just how big a problem is, that it affects all sorts of different people at all ages. It can start from congenital heart disease, so children born with a heart problem. It can develop during adult life. It often gets compounded with comorbidities later in life. We also heard about dramatic inequalities across Europe. There are, of course, issues of undertreatment of women. So there's a gender aspect to it. There's a lot of different areas. We heard yesterday, and I think it's worth recognizing today, that although we've made tremendous efforts in the last few decades in improving outcomes for people with cardiovascular disease, recently the progress has plateaued. So there's a need for more research to build new knowledge, to develop new interventions, new diagnostic pathways. So there's many potential different ways, and I can see that we're starting to get some suggestions from people. Awareness and prevention is coming through clearly. The issue of gender, so women, looking at food issues is coming through, sugar and the appropriate foods to eat, lifestyle modifications, more health literacy, which would obviously help with adherence to medication and treatment regimes, which is also highlighted in here. People want to talk about investments, and it would be interesting to find out what we mean by investments there. Somebody's highlighted stress, overall population health inequalities. We're still getting this issue of early detection, awareness, and prevention coming through in the center. Interesting, we've got a new element coming up, the capacity in public services. Again, you can add in the chat what you might mean by the public services and their capacity, so we can understand some of these things. inequities, new models. And again, if you've written new models, let us know what issues you mean by new models. Hidden added sugars. So again, looking at the issue of the food industry and population food intake. Education on healthy life and impact, yes. Sedentariness, and of course, we've all spent a lot of time, like today, sitting behind our computers on Zoom, not moving around as a result of COVID. So I think probably the sedentary nature of our lives has very much accelerated over the last 18 months. Research and innovation is coming through, as well as inequality coming through, written in several different ways. That's excellent, thank you. I think vaccination against atherosclerosis, perhaps the person who wrote that, if you could put a little information in the chat about what that means. And I think I saw Professor Achenbach nodding, that means something to you. So here we are, we've got lots of things, alcohol and CVD, personalized prevention coming up. But still right at the heart of it, it's this issue of awareness. And I think Professor Achenbach, you highlighted that very strongly with your story about the patient who was admitted, who was just 19 years old and out for a run in the woods. So doing everything right in terms of lifestyle, behavior, and everything else, it can still affect people. And I think maybe that links to the importance of awareness, that many people just don't understand the impacts throughout the whole life course, that there is a cardiovascular link. And I know that yesterday we had a very compelling patient story from someone who had a stroke very early in life and then had heart complications that they then needed to live with over a number of decades. Post-COVID monitoring, thank you for highlighting COVID. We're going to be picking up on that in our first panel. I think we can now close our poll now, and if you want to, you can take a picture of that result and you can share it in social media. I should mention that this meeting is being recorded and will be used both for a report and will be shared later. So thank you everyone for having participated and identified what you think are the most urgent issues to address. And the one message I think I take from that is that was a very busy picture. There's a lot that people think are urgent to address. There wasn't just one or two, there was a whole range of issues and looking at lots of different ways. So there's a lot for us to pick up and discuss. So let me introduce who we're going to have on our panel to help address this. And I'm delighted to be introducing Dr. Carina Ferreira Borges from the WHO. We also have Professor Susanna Price, who is a cardiologist and intensivist at the Royal Brompton and Harefield Hospitals in London. And we also have MEP Brando Benefei, and I'm not sure if we have him already because of course he has to connect in connection with his requirements to be an active member of the European Parliament. So let me start, I think, by picking up on this first issue. Why do we prioritize cardiovascular disease treatment versus prevention? Because looking at that first picture, we had awareness, prevention coming up very much. So let me ask you all, how do we raise cardiovascular disease awareness? And bearing in mind that our population is aging in Europe, and even though I've just said that it's actually a whole life course issue, it tends to develop in older populations. So the older cohort you've got, the more chances are you have the kinds of chronic conditions that would lead to cardiovascular disease. So what can we do to raise awareness and make sure that our aging population doesn't overwhelm our healthcare systems? Carina, perhaps can I invite you to start with that, to say, how do we deal with this growing problem that we have?
Thank you, Tamsin. And let me just start by acknowledging also the previous speakers, and in particular, Professor Achenbach and also Professor Birgit Begger, with whom we have long-standing partnerships, which have been very important also for the work that WHO has been developing in improving the cardiovascular disease prevention and treatment in Europe. So going to the question that you just raised, WHO has been prioritizing both the treatment and the prevention because both contribute to the fall of cardiovascular diseases burden in the region. So as you know, WHO, or you might not know, but WHO has been actively fighting NCDs through the implementation of what we call the Action Plan for Prevention and Control of Non-Communicable Diseases, which has basically as an aim to reduce premature mortality and also reduce the high burden that has been already highlighted here, which derives from non-communicable diseases. And how do we do that? These action plans are action plans that were adopted by the 53 members of the WHO European region. So meaning that it's a strong commitment from government and from Ministry of Health to take integrated action to improve quality of life, also to support people in making healthy lifestyle choices, but also to improve life expectancy and make it more equitable within and between member states. And I think this was also highlighted in the presentations before. So this plan outlines several priority actions and interventions that are really important for addressing the burden. And some of those priorities are linked to many of the issues also that have been highlighted here, like, risk factors. We heard, for example, that tobacco is a main risk factor, but it's not only about tobacco. In our region, salt and excess of intake of salt and saturated fat have been also very much associated with the increase of cardiovascular diseases. And policies that can be also implemented by countries are very important to reduce affordability of some of the substances here mentioned, like the tobacco, alcohol, but also foods, which have the high content on salt, on sugar, and on saturated fats that contribute to increased burden of cardiovascular diseases in our region. So these are all policies that are part of the European Action Plan to reduce NCDs, and again, adopted by the member states, and that should be implemented in countries to help reducing this burden. We also know that there's quite a lot that can be done, and you raised I think several of those contributing to the pooling were mentioning about the awareness. And one of the important activities that WHO has been doing as well to help people increase awareness is going to the fields. We have a project called Feed Cities, which I particularly think it's very important because we look at prepared food. This prepared food that more and more we are also consuming is available in many cities. And this Feed Cities project is a good example on how we need more knowledge about the food environment that is surrounding us. We know that if we know about the contents that we have in foods that we are consuming, governments can make policies which are adjusted to correct those food environments and formulate the appropriate policy responses. So we also have another project which is linked to the Resolve Save Lives initiative supported by Vital Strategies, which also helps countries to reduce salt intake by establishing national salt intake targets and also raising awareness about salt reduction among primary care professionals. So Tasmin, just to say that, in terms of raising awareness, also primary healthcare professionals have a very important role. And we have been collaborating, as I mentioned before, with the European Society of Cardiology and European Heart Network in making sure that these projects are implemented, but also that we raise this awareness and that we have pilot projects that can help countries to really see the difference when they implement this type of activities into reducing those indicators in terms of salt consumption that have an impact also in the house. Thank you.
Thank you. Professor Price, can I come to you to pick up on this issue about why is it that we focus so much on, cardiovascular care after a primary or secondary event and not enough on prevention? So we're still at the sort of treatment curative and not enough at some of the earlier elements.
That's a great question. I think it goes back to how we organize healthcare. Because the way healthcare is organized, if you were to start from scratch now, it wouldn't look like bringing a load of sick people into one place and managing them together. That's not healthcare, that's illness care. And the trouble is, in doing this, if you are faced as a healthcare professional with a critically ill patient in front of you, you're reactive to that. That's what you have to do. That's how our healthcare systems are set up. And it's the same for hospitals and for primary care. So until we change the way we look at healthcare to be, okay, well, at the moment we're patching up what's gone wrong because that's the system that we have. If we could move to a system that much more takes everything out to the patients in the home, where they're not patients, they're people that have some kind of investment in their own health in future, and they could understand that, I think we would change things around. But at the moment, it's a reactive healthcare service. That's what we've built. And I think it goes back to, again, looking at that word awareness that came up all the way along. Nobody says, if you talk about people with heart failure, which is a huge mortality and morbidity burden, people will talk about having a touch of heart failure or having had a minor heart attack. And there's always this minimizing of what the illness is, but they would never say they've got a touch of cancer. That would just not even touch anybody's mind. And when you look at the patients in hospital with cardiovascular disease that may have a very poor prognosis without introducing high quality evidence-based therapies, they don't have the recognition amongst their social network, amongst the support network, that actually they have a potentially lethal disease. We've been so successful in minimizing the interventions. People fear chemotherapy, but they don't fear having a PCI. It doesn't have the same stigma, it doesn't have the same label, but yet the patients still have potentially a prognosis much, much worse. And then of course, down the end, there's a whole industry built on devising interventions and drugs that will deal with the illness. And that's a very visible industry and a very successful industry. And we need to get the evidence of the effective interventions to ensure people are healthy and make sure it's possible for them to do it. So I think we've built a system that deals with sickness. We've built a whole industry around that. And by that, I don't mean industry in a pejorative term. It's the researching, it's the publications of changing outcomes by those interventions. And de facto, we built a system that brings sick people together rather than focusing on people at home and giving them the opportunity to be healthy.
Thank you for that. And I understand that MEP Brando Benifei is now with us. So thank you and welcome.
Hi.
Just let me bring you in on this because earlier Professor Achenbach presented some really quite dramatic figures about inequalities across Europe. And if you have cardiovascular disease, your chances of surviving are dramatically different, ranging, I think, from 170 deaths per million to several thousand. So this is a multiple, tenfold, hundredfold difference. So frankly, clearly, if I was going to give someone advice, I'd say be born in a country where you've got better outcomes. Is that something that matters at European level? How do we change the public and political perception of cardiovascular disease and inequalities and access to care? Professor Price just said part of the problem is people, don't see it as being, we've been successful at having some impact, so people don't have the same level of fear and concerns about cardiovascular disease, so that's a perception challenge. How does Europe address the fact that we have these big differences across Europe, and how do we change the political perception and make it more urgent to do something on cardiovascular disease?
Yes, I hope you can hear me.
Yes, we can.
I have some, I have some connection issues, so I hope it will be stable. Today I'm in an external group meeting of my political group, but I wanted to really be able to give a little input to this very important debate. Thanks for inviting me and organizing it. The Parliament is very close to this fight. With the MEP hard group, we are pushing member states and also at the EP level to act. But it's not only a parliamentary action that is required. You just touched, the main problems that we see. And I think that it's very important that we involve civil society, patients, experts, and EU institutions as a whole to address in particular the issue of complacency, because we have huge geographical and social inequalities in CVD mortality across Europe. It's unacceptable that if you live, for example, in Bulgaria, you are 8 times at a greater risk of dying from stroke compared to someone living in France. So it's very important that we build awareness campaigns that are running along generational lines. I think it's important to support early diagnosis, and older people for sure need to be supported in this, especially after this period of COVID, where a lot of other non-COVID related health actions and checks and decisions have been postponed or limited. It's important that the European Health Commissioner, Kyriakides, when launching the cardiovascular blueprint for EU action, said that cardiovascular disease is the leading cause of death in EU. We know this very clearly from abundant evidence, but it's important that is expressed very clearly by the institutions. So earlier this week, there was the launch of the European Alliance for Cardiovascular Health. We have in these days the World Heart Day. I think it's important that we build this awareness, because there is not this understanding. And this means that we also need to then take specific solutions in terms of policies. We have the EU for Health program, and we are now working on the work program for 2022. And we are sending a letter with my colleagues from 7 member states, so European Parliament and national parliamentarians, calling on the Commission to fund under this work program a joint action on structural heart diseases. So it's very important for us to continue getting inputs as we got from the stakeholders in the field, so that we can strengthen coordination of policies, bring this topic into the debate of the Conference on the Future of Europe, where the debate about the health union or a new level of health union for Europe will be debated, so that we can build more and more this momentum, so that we can see more targeted policies with financial support, but also with learning by the best practices that we have all over Europe, knowing that patients must be at the center, and that politically the COVID experience has built a new willingness to work together by the political forces to act on these health issues. We should not lose this occasion. And so this is why, as I said, we are sending this letter tomorrow, and we are working on these on all these networks and these actions also at European level from the European Parliament. Thank you very much.
Thank you very much for sharing some of this insight, and also some of the actions that the European Parliament members are trying to take to really push this issue up at the agenda. We're also starting getting some questions from the audience, and I'd like to bring in a couple of them. And I'm going to invite Professor Achenbach and Birgit also to suggest that you could answer some of these. Laura Cohen has asked us, look, you can tackle some lifestyle issues, but that's not enough, because often cardiovascular disease are diagnosed only after you've had an acute event. So what can we be done to have adequate primary and secondary prevention and early disease interception? Now, Professor Price mentioned a little bit, but Professor Achenbach, can I bring you on this? How do we get early disease interception? Because by the time somebody makes it to your clinic, it's often too late for the early disease interception. So I'm guessing that's moving further up the primary care chain. And Birgit, I'm going to come to you to pick up on 2 questions that have come in about how do we share individual responsibility and group responsibility, because Dr. Borges talked about the food environment that has an impact on, you know, the hidden sugars, the added salt in food that people may not know about, that affects their risk profile. And if we have more prevention, let's make sure it doesn't sit on the individual's shoulders, but we look at the bigger commercial social determinants. But somebody else says, well, if we're going to have more of a shift to prevention and awareness, does that mean the individual has to take on more responsibility? So we have a bit of contradiction there. Professor Achenbach, would you like to pick up on this issue that, you know, it's too late for many people if they're actually seeing you? You're on mute.
Beginner's mistake. That was the first question. You know, many people show up too late. I think this refers to a very specific segment of heart disease, which is coronary artery disease and the heart attack, you know, the acute coronary syndromes. And it's absolutely true that patients often show up with a heart attack, with an acute myocardial infarction, as the first manifestation that they are heart patients, and nobody had even thought about potentially having heart disease. It's very difficult because some of these patients will be truly completely asymptomatic until the event. And screening programs won't work. I mean, we could talk a lot now about screening. For this purpose, you would identify too many people who really don't have a problem. It's, you know, screening is difficult. But when you talk to these individuals very carefully, more than half of them have some symptoms days to weeks before the event. Now, this is where awareness, you know, the word that was written the largest in our word cloud, makes the major difference. If people only knew that they feel chest pain once in a while, they certainly have to go to the doctor immediately. So many lives could be saved. Now, how is this achieved? Many levels. Educating the primary care physicians, educating the public, having health education in school so that the kids know about it as they, you know, go into life and they can tell their parent what is important. So many levels to increase awareness. For this specific problem that was addressed here, that many patients with heart attacks come too late, awareness is a key component of what we can do about it.
Thank you. Birgit.
Yeah, question individual and collective responsibility. I think I tried to touch a little bit when we look at prevention. Yes, there's lifestyle, but I think what was needed really is that there is an environment, a healthy environment where the individual can choose. So you are not necessarily forced to eat very salty, very fat, very sugary food because you are A, aware of it, and B, you can inform yourself through, for example, food labeling. There are labels on food, so what is in it, and you can choose, oh no, this one is too salty, this one is too fat. So that, and I look at alcohol labeling is another topic. We can see what does it contain. So I think there is both. We need an environment where which is regulated, which invites you to take a healthy choice, because it's the easier choice maybe than buying cheap and unhealthy food. But that it doesn't stop just with food and alcohol. It is also how we plan our cities. Do we have are we invited to walk to work? Are we invited to do a sports session, or is it complicated? Can we join a club easily or not? I think there are many elements where the cities can do a lot at city planning, but it's also the air quality. I mean, WHO has guidelines on this, and we would need that in the EU as well, implemented really, so that we breathe an air which is more healthy. So we just don't only find it in the forest, but that we also can walk in a bigger city without taking a hazard. So I think there's on the one hand side the responsibility of the policymakers to do everything to implement a healthy landscape and healthy environment, but then it's also the awareness and the responsibility of the individual to make the the healthy choice to see that this will be the one where I will in the end benefit, and my family and the kids who are coming then in, etc., etc. And that I think is what we need to strive at, to see that health is a wealth for everybody. And if everybody tries to work on it, I think overall the society will have a better fundament to drive and to develop.
Thank you. Let me now bring in Professor Price, because of you have this double experience as both a cardiologist and intensivist. And I want to touch just a little bit on the impact of the last 18 months, because as a result of COVID, a lot of people couldn't get to hospital, couldn't have treatment. So people are now perhaps arriving with late stage disease. We also know that people who've had COVID, that have cardiovascular complications, and it was the #1 comorbidity resulting in death, and as a result of long COVID. So there is clearly an enormous challenge to deal with. Well, first of all, could you just give us some sense of the impact of COVID on the treatment environment for cardiovascular patients? And then secondly, we're talking about improving population health. Is there anything we can do to improve cardiac resilience for a future shock that we don't know about yet?
Okay, so the first thing I think I'd have to say that COVID-19 isn't a black swan event. We knew it was going to happen at some point. We had early warnings with the swine flu pandemic a decade ago, and I remember hearing some extraordinary presentations looking at bird flu and swine flu being in the swine vector. So we knew this was coming. And I think to understand what really happened to our cardiac patients and other patients, the extent of reorganization of healthcare for those who actually weren't working in it, I'll just give you an idea of what generally happened. So what happened was pretty well everything was turned over to the emergency that was facing us. So there was extensive reorganization of healthcare for cancer patients, for cardiovascular patients, for every type of patient. Highly specialist teams were redeployed to the intensive care unit. So cath labs closed, operating theatres closed, all of the outpatient sessions went to remote. And what that meant was the patients who were most disadvantaged, the cardiac patients faced double whammy. #1, having cardiovascular disease was a risk factor for increased mortality. And #2, those who needed to be seen face-to-face, although the remote clinics were a great development, not every patient can be managed remotely. And some of these patients, particularly complex congenital patients who need to be examined, so these are the younger patients, patients with pulmonary hypertension, obstetric patients with cardiovascular disease, these patients needed to be seen but were massively disadvantaged because they couldn't be. On top of that, with the reorganization with everything being turned to manage this tsunami that was coming at us, theatre lists for patients who needed evidence-based interventions that were potentially life-saving or life-prolonging, they were stopped. And in many countries, everything except for emergency cardiac surgery ceased completely. And there were effective triages for these patients, but the number of operations that were undertaken during the pandemic were lower. Now, many countries now have got up to 90% plus of their pre-COVID activity, but we're still being impacted by the screening that has to happen, the bed spacing that has to happen. So there's a lot of practical issues around trying to maintain the flow of patients. So it's not just about the number of patients, it's about the flow of patients. We saw that there was a more than 50% reduction in patients presenting with acute myocardial infarction. That wasn't what we were expecting at all. In previous pandemics, we've seen, or epidemics and pandemics, we've seen an increase in presentation. We saw a reduction, and the reasons for that have been discussed very, very widely, I think, in the literature. So the patients who were disadvantaged the most were the patients who really needed to be seen the most. And we now have to work to get back to deal with the backlog and make sure that we intervene where we need to intervene and get patients seen as best they can be. That's not easy, and I think also anybody who was involved in reconfiguration of healthcare services to deal with the COVID pandemic, restarting services in cardiovascular was more difficult than it was to just stop everything and turn everything to COVID-19. So that's the sort of how it looks, and we're now living or having to live with maintaining a safe pathway for our cardiovascular patients that need intervention and need to be seen, so they can feel safe and that they are safe, that they are separate from patients who may be infected, but maintain the flow of whatever it is that they need for their intervention. And we're going to have to live with that. So we need to look at how we use our hospitals, how we look at our, the future hospitals. So you're going to have wholly elective hospitals where patients are protected and come in and have their interventions. And to what extent is that feasible? It's not feasible everywhere. Many hospitals have an open front door with an emergency department. So you can't have all completely green and completely red or red amber hospitals. We just can't do that. I think, to my mind, there were some lessons that came out of the COVID pandemic that were extraordinarily helpful. So first, to me, especially when I look at cardiovascular medicine and specialist cardiac centers, the resource of highly trained staff to be able to be flipped, to be able to work in different environments is extraordinary. They're used to using complex technology. They're very, very uniquely flexible resource, and they were a massive resource during the pandemic. I think that the discussions about societal or social and societal justice, ethical decision-making, research in times of pandemic, the use of high-tech healthcare in the time of pandemic, we're beginning to have those discussions now, and there's a lot to learn from them. We learned a lot about education and training. So if we think about our workforce of the future, we need to have a flexible workforce that's fit for the future. That's actually not, it's not about what I want to do as a doctor, it's about what society needs me to do. So this flexibility of the cardiothoracic and cardiovascular workforce is extraordinary. And I think the other thing is that we learned that hierarchical models of education and training in healthcare, probably we should bin them, and we should start looking at task-based models for intervening in healthcare. Waiting until you've had a nurse that's been trained for 10 years before they do the more complex, it's not actually necessary. You can move people sideways and then you can redeploy them. And then finally, I would just go back to saying this was completely predictable. It was predictable and it was predicted. And I think we need to be very clear going forward, what is our centralization plan, what's our local deployment plan, and make sure that we deal with all of the patients that need ongoing care, not just the one. I guess it goes right back to my first thing when I said that we're very reactive in healthcare. We deal with the patient that's in front of us. We need to have a plan that encompasses a flexible workforce, redeployment where we need it, a recognition of the people factors in it, so we don't cast aside any patient populations. I mean, we need to advocate for our cardiac patients. If we can't advocate for them, then who can?
Thank you very much, Professor Price. I mean, just giving us an insight into how things have been for the last 18 months. And as you said, this was both predicted and predictable. Professor Achenbach, would you like to briefly come in on this?
Yeah, absolutely. Thank you, Susanna, for giving us this first-hand insight on what it really means if you're inside and have to take care of the patient with COVID-19. What, of course, moves me a lot is, as the president of the European Society of Cardiology, thinking of all the patients with cardiovascular disease, you said we knew this was coming, so we also know this is coming again. And how can we make our population as resilient as possible against whatever might strike us in the future? And it doesn't leave my head that I think they should be as healthy as possible. If everybody was free of heart disease, wouldn't they have such a much better chance of surviving a bad infection? And what is the impact that you saw on the patients that you took care of? Who were the ones who were really the hardest hit by COVID-19? And what can we do to make our population able to, withstand such a crisis in the best possible way?
Thank you. Professor Price, do you want to briefly respond to that? And then I'm going to bring this panel to a close.
Yeah, sure. I think, well, clearly age is a big factor and we can't do much about that. And I think we have to be very, very careful when we start highlighting certain patient populations, so the older patient population, and maybe pitting them against the younger population that we saw. And I think we have to be very, very careful that that doesn't happen at all in the future as much as we can manage it. The patients who we saw in the first wave in particular were largely diabetic, overweight, and had cardiovascular morbidities, comorbidities. So those were the patients who got sickest. They were the patients who ended up in intensive care, and that, as a result of that, we had to stop a lot of the high-tech interventions that we would do for patients that might need intensive care or might need level 2, level 3 care. So I think your point, Stefan, is extremely well made. If cardiovascular risk factors put you at risk of developing respiratory disease complications and ending up in critical care, addressing those is absolutely vital, and helping people understand that there are things they can do to mitigate their risk of dying from respiratory disease or future pandemics. But again, we must be careful that it isn't a battle between the older generation and the younger generation. Cardiovascular disease affects patients of all ages, and we need to be mindful of the spectrum of cardiovascular disease, not just ischemic heart disease.
Thank you very much. And I'm going to say a warm thank you to the members of our panel. I appreciate there was a lot to say, but we are running out of time on this panel. But it's a wonderful bridge to the next conversation, which is, what are the building blocks of an EU cardiovascular disease plan? And Professor Price has just reminded us why it's so important to get it right. If the current pandemic that we're going through is both predictable and predicted, that means we know there is a future threat, possibly only a few years away, possibly a decade or more away. But the importance of getting our population as healthy as possible to build in that resilience, I think, is absolutely clear. So thank you very much to Professor Price and to Professor Borges from the WHO for joining us. And I'd like to welcome in some new members of our panel, and I'll also be going to poll you again using Slido. So in the meantime, let me welcome Pierre Delceau from the European Commission, the Deputy Director General for Health and Food Safety, and Professor Janina Stepinska from the World Heart Federation. So they'll be joining our panel, but in the meantime, let me poll you again, because this time we're going to ask you, what is the critical area to focus on to improve cardiovascular disease health and resilience in Europe? And again, we're offering you some choices. We're giving you 4 choices, and then if you are in the anything else, let us know in the chat what else we should be addressing. So we know that we need to invest more and do something about cardiovascular health to build our resilience to future threats, as well as manage the environment around us. We heard earlier that there's issues with air pollution, city design, the way that we work, the way that we move, as well as food and consumption patterns. There's lots of different areas outside the individual where there's policy interventions that work. But so far, about half of you are saying that it's prevention through healthcare management and patient education. And about 40% are saying we need a proper cardiovascular disease policy to make it, and that's shifting. We're about at equal now, and given that our focus and the title is that why Europe needs a Beating Cardiovascular Disease Plan, we're hoping we're making the case to you that nothing gets done unless it's planned for. And if that's, if we recognize that COVID-19 was not a black swan, it was both predicted and predictable, we can see that as our population ages and changes, we've got changing lifestyles, having a plan and a policy in place allows us to make a sort of cross the policy area approach that would improve population health. So I think I'm going to stop the poll right now, and we can see that having a cardiovascular disease policy or plan is there. It's the leading answer that we had straight away. So welcome to my panelists as we look at panel number 2. And here we're going to be looking particularly at what we can do at European level. So let me start by inviting Professor Stepinska to answer a question. Here, what I want to understand is, where do we need the change most across the cardiovascular disease prevention pathway? Is it at the prevention area? And that came through very strongly in panel 1. Is it in chronic cardiovascular disease care? And highlighting some of the enormous discrepancies and disparities in the outcomes for patients tells us also we need to work there. So where do we most need to make a change?
First of all, thank you for inviting me for this very interesting meeting. And it is a pleasure to be with you. I'm a cardiologist as well, working in intensive care. And first of all, I would to comment the voice that we had just a moment ago. And I am not surprised that we are discussing about prevention as well as cardiovascular policy, because we are right now in a very special moment, looking for the pandemic and looking for all, let's say, European politics in cardiology. First of all, I would like to point that we have the first effect of the pandemic, which means that it is visible already, and we have increased mortality. It was very well discussed in the first panel, but we are sure that we will have right now the second effect of the same, of this pandemic delayed, because we will have growing epidemic of, for example, heart failure, obesity, diabetes, because we changed lifestyles. We have a lot of increasing risk factors. So in my opinion, on one hand, we should put the most possible attention for prevention, which is quite easy to do it equal across the Europe. But the second thing that we should discuss, and it is much more difficult to decide how to do, is cardiovascular disease policy across the Europe. Because we can see exactly that the differences, this epidemic exposes the inefficiency of the healthcare system across the Europe. It is really different between the country. I'm from Poland. We are the, let's say, middle income country, and I can compare that with other countries and how it works right now. So I think that this part is very difficult, and it should be really discussed in European level, how to change that. Because I believe in education, and it helps very much with the prevention. If we start the education very early, and it could be done across the Europe to start this education, let's say in primary school, and it would be for sure helpful and help with the prevention later on. And primary prevention, in my opinion, is, it's very difficult to compare what is more important, but if we put the attention to the primary prevention, that it should result in decrease of cardiovascular diseases, decrease in mortality, and this group of patients is prepared to follow secondary prevention. But I think that right now, in this situation when we are, this policy is much more difficult and is really important to improve the situation in Europe, which is very difficult right now, because during last years we observed a decreasing number of cardiovascular disease and a decreasing mortality. Then it was a plateau, and right now, according to the pandemic, or let's say syndemic, we can see a really dangerous situation across the Europe.
Thank you, Professor Stepinska. You've mentioned and highlighted again the importance of prevention, and that came out through in the panel earlier. Let me now invite Pierre Delceau to comment a little bit, because there's a minimum of 20% of the EU for health budget that's dedicated to health promotion and disease prevention, which sounds like great news. How do you expect this could impact the policy landscape related to cardiovascular disease, given that we've talked about the fact that, yes, there's food policy, labeling and others, there's alcohol, but there's also green spaces, cities, mobilities, etc. How do you see that 20% of money being focused on disease prevention and promotion could affect the landscape for cardiovascular disease?
Thank you very much, Tamzin, for your question, and good afternoon to everybody. I only have one regret, not to be present in Austria, because apparently it seems to be a very nice place, and I hope next year we'll be able to do it physically, and also hope I will be able to do it physically, because it also means that the COVID crisis will be behind us. That would be, of course, a very positive signal. Now, of course, I was really impressed by all the, the speakers in the different panels, and also by the figures given by Professor Achenbach. And it's clear that, heart disease cannot be ignored. It's really a problem. And of course, it was striking the difference of situation according to the member state, which I believe is something which is not acceptable from a EU point of view. Now, focusing on your question, and again, having listened to the different speakers, it's clear that the issue of prevention is something which is extremely important. And a lot of actions are already being undertaken at the EU level, but also at the EU level with member states, because let's never forget, of course, that when we talk about health, member states have quite a lot of competencies. And of course, we don't want to change it. So it's clear that we have a lot of actions that we are already conducting with the member state or at the EU level, looking at the prevention. You already mentioned quite a lot of them. You mentioned what we do on, even on the context of the cancer plan, but against obesity, smoking, physical inactivity, alcohol consumption. I don't want to name all of them. You know what we are doing, but of course, this is something which is extremely important. And of course, in this context, tobacco and the actions that the Commission has undertaken, the EU has undertaken on tobacco, is something which is extremely important. So first element, prevention. We do a lot of things with the member state. We look at best practices. We look at also different aspects of the behaviors, food, and so on, which could affect, possible and create heart diseases. And we want to address those issues. We mentioned also, and you mentioned it also indirectly, as you know, this commission is probably the greener commission that has ever existed. So we have a lot of actions to have a more green Europe, to have a lot of actions to try to make sure that we have less pollution in Europe, that we have, in a much better situation. And again, we are addressing this issue, of course, because we want to have, a greener environment, but we know also that by having a greener environment, we will have also, it will also prevent some of diseases like heart diseases. And so we believe this is something which is important. Of course, it's a long-term action. I don't promise that we will have a solution within 2 weeks. Of course, it's clear. It's a long-term action where we need to convince also the member state and all stakeholders, but that's something which can make a difference and which can be, long-term, medium, and long-term will really help to improve the situation in Europe. Now, finally, you mentioned EU for Health. EU for Health is there. It's a huge program, for the health sector, at least. It's the first time that we have so much money in the health sector. And as you say, 20% of the budget should be targeted on health promotion and disease prevention. This is really a complete change compared to the past, compared to the current situation in which we have been so far, because it's true that, on the past, the EU has financed a few actions linked to these issues, and especially linked to the heart diseases, but it's clear it was a relatively small amount of money. So on EU for Health, I would like to say a few things. First of all, we are now in the process of developing the program for next year, so the work program for 2022. That's now that we are discussing, we'll be discussing with the member states. We will have a budget of, close to 700 million euros to spend only for next year. That's quite a large amount of money. Of course, not everything will go to promotion and disease prevention. Let's be very clear, let's be honest with you, but still quite a large amount of money could go to this topic. So my message to you is really, we are there to listen to you. And I already said it in several conferences or 7 meetings with some of the speakers today, but it's clear we expect you to come with concrete ideas. I've heard all this debate about the plan and so on. What we need now is concrete ideas which can make a difference that could be financed through EU for Health program. Not only this year, of course, but also next year and the following years. I believe this is the most important actions to be done now, is really try to help us to prepare and to find actions which can be financed through EU for Health and which will make a difference. And that for me would be something which is extremely important. I would like also to add some of the actions that we are going to finance also through the EU for Health are linked to the Beating Cancer Plan. But of course, some of those actions have a consequence also for heart, because as you know, when you talk about prevention, you take actions to prevent against cancer, but at the same time, you also prevent, the heart attack. If we talk about tobacco, if we talk about alcohol, for instance, just to give you a concrete example. So to come back to your real question, I would say, let's hope that we will get enough good ideas to finance through EU for Health program. It's a huge opportunity for the sector. It's a huge opportunity to do better in the health sector. Let's try to benefit from it. Let's try to take the advantage of it. And again, the COVID crisis has learned us, very painfully, I would say, a hard lesson. Health is important. And if we don't address the health issue, all of us will be at the end of the day affected. We cannot ignore health issue. And heart disease is a very important issue in Europe. We need to do everything to try to improve the situation of all Europeans. And again, I would like to come back to something Professor Achenbach said. We need to make sure that there is a level playing field in Europe. We cannot have second-class citizens in Europe when we talk about heart disease and actually other diseases. I would stop here.
Okay, thank you, Pierre. Let me now pick up on a question that we've had for the chat, and I think I'll ask Professor Stepinska to respond on this, because we've had a question which says, you know, innovation in the cardiovascular sphere seems to be lagging behind a bit, and looking not just at the EU for Health programme, but at the Horizon Europe programme, which funds innovation and research. You know, where do you feel that we could make the most progress in developing innovation in the cardiovascular environment?
Well, this is a very important question. We are concentrate on innovations in all means. I mean, we are concentrate right now in science, that's one thing. Then in try the new techniques, new pharmacological treatment, as well as new technology to take care and to everyday practice, which is one of the most important part of our, let's say, of our everyday life. So I think that the problem with the innovation is that we have a lot of new ideas in all of these fields, but some of them are not possible to be implanted in whole Europe. So we should, you know, according to the evidence base from large trials, we can choose this kind of innovation that change, let's say, the prognosis or the results of treatments. And our ambition should be that this kind of innovation could be implanted in whole Europe, as, let's say, in the same time. Because this is one of the reasons of such a large differences between the countries in Europe.
Okay, excellent, thank you. So making sure that we attack some of these disparities across Europe and we have equal access to what we have already in terms of best practice and high levels of treatment options. Let me bring in Birgit for a moment, because we've got an open invitation from Pierre there to say, okay, come in with concrete suggestions, things that are fundable through the health programme. And that's great, that's very welcome, of course. But what's the difference between having a series of disparate projects and having a cardiovascular plan? You know, why? Because yesterday there was the launch of 15 organizations who came together for an alliance, and you were calling for a plan. Why do you see a plan so important rather than having different projects?
Thank you, Tamsin. Yeah, no, a plan. If you don't have a plan, if you take care of the process, you will that the result will follow. But if you don't have a plan, if you don't have a process, you risk to fail. And that's what I fear if you only have treating a bit under the EU cancer plan, if you're doing a little bit here and there. This is just not the scope of the crisis, of the CVD crisis we are having, and it's just not enough. So I think a plan is really important to work in a structured manner to tackle all the aspects we've been discussing: primary prevention, secondary prevention. We need research, we need innovation, we need to tackle the healthcare in itself, so that there is a continuous pathway for the patient through the primary care, secondary care, tertiary care, so that patients do not fall in between silos. And therefore, we need a plan which also tackle all this, plus the risk factors. But we need a plan dedicated to CVD, because it is just such an huge burden for Europe and for the European Union. And looking at the disparities, we will not arrive at a Europe which serves its citizens if we have these discrepancies and this social injustice. Here we are. And one item, I think in a plan, we would also need to include a civil society and have a mandate here. We need to bring everybody to the table to have solutions. And speaking of equality also in power and bring in opinions, what is lacking in the EU for Health program, and we're looking at the European Commission, we need operational grants for all these organizations who bring in expertise and bring in their knowledge. But on the other hand side, they are much, let's say, capable of doing so if the European Commission does not support them in their work. So the question of operational grants, in particular in the health sector in these times, is very, very important. So that would be one point to look into the EU for Health program and see how this wealth which we have with the program, and which is wonderful, 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 but how we can harvest it and how we can make the best out of it. For the concrete recommendations, I go back to the brochures. We have 23 recommendations, very concrete in here, policy recommendations, which tackle the regulatory scheme, which tackle innovation, research. So we've put it on paper, but of course we are happy to discuss it. Also how it fits into the EU for Health program more concretely, what we are planning for 2022, because I understand 2021 is coming to a close. So we are happy to do that. And as I said, we need not just piecemeal, we need a proper plan in order to respond to the magnitude CVD is representing in Europe. I think otherwise we will not succeed. Otherwise it remains scattered and we will not move forward. But there's too much pressure, I think, out there.
Thank you, Birgit. And I understand that we have a member of the European Parliament, Mr. Justas Olekas, who is in the audience and would like to also contribute. So, Mr. Olekas, if you would like to unmute yourself and put your camera on, it would be great to have your contribution. We're just at the point of saying the message from the stakeholders is that the size and urgency of cardiovascular disease pre-COVID required us to do something, and post-COVID it's even more urgent. We need a plan as well as building blocks. What would you like to contribute?
Thank you very much indeed. A very interesting conference, and I would like to add that I fully agree that particularly after the COVID just deepening the problems in cardiovascular disease and show that we should act all together, very united. My proposal is that we should more put attention in this half a year in front of us to more deeper engage the conference of future of Europe, where we discussed about how the future of Europe should be organized, the health union, what is the responsibility maybe transfer to European Union. For example, the minimum standards should be implemented in every country. Just cardiovascular diseases network present that they have recommendation, federal recommendation, but how we can implement them and how we can push member states to implement them. I think we need to have the European Union minimum standards for the primary, for early diagnosis, for the treatment, and only in this way we can input to solve these inequalities in different member states and inside the member state. Thank you very much.
Thank you, Mr. Olekas. And I'm going to invite Pierre perhaps to respond on something, because I noticed that Professor Achenbach has come back, and I'm very struck by something that you said earlier, which was that you're a cardiologist, and you treat patients, but you devote a significant proportion of your time to this area of advocacy and putting a policy program in place and calling for it, because clearly you see that will have an impact on the care that you can offer to your patients. So Pierre, can I invite you to address Professor Achenbach? You said a few months ago that your door was open and you were ready for ideas, and now you're saying you need concrete fundable ideas through the EU for Health program, and that's great. But what advice would you give Professor Achenbach, who's given up some of his days from clinical consulting to try and make an impact politically, to say it's a bit like the climate crisis. We need to get the people and policymakers to understand the urgency before they can put the necessary resources and political focus on it. So Professor Achenbach, what advice could you give him, Pierre? Because he's taken some time out of clinical consulting to try and have political impact. What would it take?
It's a paradox. Normally, I mean, I'm not supposed to give advice to the stakeholders. It's for the stakeholders giving me advice. That's the way it should function. But anyway, I would like maybe to react to a certain number of points and follow what you said. First of all, my door is still open. So that's clear. I mean, I'm not closing the door. I'm not saying I close the door. My door is still open and the doors of my colleagues is still very open. Second element, it's clear that CVD is a real problem. Nobody is denying it. It's clear that it's something we need to tackle and we need to address this issue. Now, I'm a very pragmatic person, and I've heard what you say about the need to have a plan and to have to create a policy and to have a plan, and I've heard what Birgit has said and the importance of it. My only point is simply, at this stage, we don't have such a plan. And such a plan will not be done in just 1 or 2 weeks. It's something which, will be medium term, will take some time. What I'm just telling you, we have also to do things now, and we have a short period to try to react. So I'm not denying the discussion about the plan. What I'm just telling you, we are in the situation where we don't have a plan for the moment, but let's try to make the best use of all the possibilities that are before us now. And that's my message to you. And that's why when I talk about concrete action, I know I've read your documents about the policy recommendation. It's a very good document. I received it in one of my previous meetings or discussion. My point is simply, again, when I talk about the work program of EU for Health, it's concrete actions which can be financed. You see, we need, for instance, and we need to do it now. And when I say now, it's not in 6 months' time. It's really between now and one month maximum. That's we only have a windows of 1 month to do BL, because again, the plan will have to be adopted, work program will have to be adopted before the beginning of next year, before it's being implemented. So that's my message to you. I'm not closing the door to have a more in-depth discussion on the idea of having a plan, and I've heard your arguments. I understand why you mention it. My point is simply, let's try to be concrete also and fast now. Because if we spend too much time talking about a plan and losing time, because then you will have different stakeholders, Parliament will intervene, of course, rightly so, member state and so on, we could still be discussing a plan for quite a long time. I'm not saying we should not do it. I'm just telling you, let's focus on concrete steps now. Let's try to implement them because there is an urgency. And as you say, COVID situation in which we still are, does not help. Let's be very clear, because as several of you have said, some patients were not treated, or some treatments were delayed or postponed or not taking place at all. So that's not very good. And so we have an urgency now. Also, let's try to see what we can do. That would be my message. But again, it's difficult for Commission officials to give an advice to stakeholders. That's you're asking me too much from that. But otherwise, I'm open to discuss and continue the dialogue with all of you, of course.
Thank you. Professor Achenbach, would you like to respond?
Absolutely. I don't think I have to respond. I can parallel what Pierre has been saying. It's not that we are just saying we need a plan in the future and we're not doing anything right now. The ESC, our organization, is very active. We're having many conversations with individuals in Brussels, in the EU, and we are very happy. We know that the doors are open and we're using these channels on numerous levels. One point I would like to make, one point that I think has not been sufficiently mentioned so far in the discussion. We've talked a lot of prevention. We've talked about healthy lifestyle. Everything is very important. How did we bring down, for example, the rate of death if you have a heart attack? If you don't do anything, 30% will die. With modern treatment, about 4 to 5% will die. It still remains a massive problem, but we have made progress in the treatment of cardiovascular disease. How was it made? It's high tech. Pharma is high tech. Drugs are highly effective if they're given to the right people. Intervention, revascularization of heart attacks saves a lot of lives. Intensive care medicine done with the right algorithms and with the right technology can save a lot of lives. This is high tech. We need to invest in development and research, and the EU has to support this so that we, first of all, develop these technologies for the benefit of the entire world, bring down the mortality of those afflicted by heart disease in our population. Research and development are key, absolutely key. One of our most important weapons, not the only one of our most important weapons to tackle the burden of cardiovascular disease.
Thank you. Pierre, I noted you just want to come back briefly because I need to close our session.
No,
Yes.
very briefly on something you say, and you say, Stéphane, if I may, or Professor Kalmbach, I don't know, I should call you. But anyway, I would say you say something extremely important, of course, now. It's clear research is fundamental, and we need to do something. High-tech is there, and we need to be able to do it. One element on which I would like to insist, maybe apparently nothing to do with what we're talking now, but which is important. As you know, we have a project on building a European data space. Health data space. I believe this is something which is extremely fundamental because, you know, if we are able to gather all the data which exists in the field of health at European level, of course, protecting data protection is key. But if we're able to do it, you have a huge amount of data which could be used actually to develop research and to develop new technologies, new medicines, and so on. And I believe that's also, you know, something high-tech project which I believe is important, but could also make a difference. Maybe not only for this sector, for CVDs, but more globally. But it's still something which is extremely important. I will stop here because I know something you have to close it.
Very well said. Yes, we fully agree.
Thank you very much to all of you for engaging in this panel. And I apologize, Pierre, if I put you on the spot to go beyond that. But I think we were looking for your advice on how to make political change at European level and benefiting from your experience. Let me now, we've got a short video that we'd like to show you called Getting to the Heart of the Matter. And I think now is the moment to watch that video. So let's see it. So thank you very much. We've come to the end of our webinar. I think it's been extremely useful and helpful. I want to thank all of our panelists and participants for engaging and to issue an open invitation. Yesterday saw the launch of the European Alliance for Cardiovascular Health, EACH, and we'll put in the chat the link to the website, and we encourage you all to become involved because the message of the stakeholders who've come together, which were public, they were private, they were researchers, they were patients, they all came together on the understanding that given the size of the problem and the impact on the European population and on its economy, we're not doing enough and we're failing the patients who need it most. And that is the basic logic behind the EACH Alliance. And therefore, what we want to do is gather momentum so that we have the invitation from Pierre to keep putting in suggestions in the very short term, concrete ideas that could go into the work program for this year and next year, but over the next 3 years to build up the momentum so that we can get a consolidated European approach to cardiovascular disease that would align the focus and resources and attention to cardiovascular disease that's appropriate given the size of the burden on the population. So we count on you all to be active members of this, and there's the invitation to endorse the Alliance, to be part of it and to join the momentum to create a wave of pressure for change, because we can do better and we should do better on this issue. So thank you to all of our panelists, to Professor Achenbach, Professor Stepinska, to Birgit, to Pierre, and to Professor Borges from the WHO and the other speakers we had earlier. Thank you to you for participating as part of the European Health Forum Gastein, and to Amgen, which made it possible for us to have our session today. Let's keep the conversation going, and immediately after I close this meeting in just 1 minute, there will be an opportunity for you to join a reflection process that's hosted by young Gasteiners to explore what to do next, where to go, how to build up the pressure. And this is both a call to action and an invitation to be part of a process to create political change. So if everything that you heard today tells you that we're not doing enough and that the current status quo is unacceptable and we can change it if we communicate and act together, then go to the reflection room and explore it more, and go to the each website and be part of the change. Thank you all for participating. I wish you good health and good luck. Goodbye.